This is LiveWell Talk on harm reduction for substance abuse disorders. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point Health, St. Luke's Hospital. Joining me today is Dr. Chantal Rozmus, a psychiatrist with AbbeHealth. Today, she will share the concept of harm reduction, what its meaning and application, as well as how to support individuals who are suffering from a substance abuse disorder. First of all, Chantal, welcome. This is your first podcast.
Yeah, it is. Yeah. I'm excited.
So you're a psychiatrist? We've never
Yeah.
met in person. I don't believe we have.
I don't think so. No. Yeah. Like you said, my name's Chantal. I'm a psychiatrist down at the Abbe Center in Iowa City.
So why psychiatry?
Yeah, it's a great question. I went to med school to be a family doc. I wanted to go to back to rural Iowa. It's where I grew up, and do family medicine. And second year of med school, I would have told you I'm not sure if I'm going to do that, but I'm definitely not going to do surgery or psychiatry. Um, and then I had my first rotation, and it was family medicine, and I really loved it. The days that I was happiest, though, were when I had psych patients. And I went home happier. I was just in a better mood, and I'm afraid of burnout. It's a long road to get to being a doctor. So I figured if I liked what I was doing during the day, then maybe I'd be less likely to burn out.
Oh, that's a great way to approach it. But that kind of gets us into, because people that get burned out or are unhappy with their job can be more susceptible to abusing substances and have concerns from that standpoint. We certainly see that. But, I think let's start. I think people have a good concept of a substance abuse disorder, right? The listeners do. They can kind of put that together. But harm reduction. Harm's bad and reducing it's good. So this must be something good. Tell us what it is.
Yeah. So, there's kind of two definitions. There's like the capital H, capital R harm reduction, which is this sort of grassroots movement to support people and meet them where they're at and love unconditionally, is the way that I think about it. And then there's sort of like the lowercase HR harm reduction, where it's just like the individual practices. And so um, it's the idea, like it's exactly what the name says. We're going to reduce harm, right? So how do we do that? I think within the substance use realm, it means like people are going to use drugs. They're going to, it's going to happen. And showing up for people and saying, if you have a substance use issue, like, I'm still going to be here. You still deserve care. You still deserve everything that somebody else who doesn't use deserves. And so that includes like, being safe. So things like sterile needle use, things like condoms are harm reduction, right? Testing your drugs that you're using is harm reduction, to make sure that you know what you're using. And for some people, their goal is not to stop using. They just want to have a better relationship or a healthier relationship with the substance. And so there's a lot of different ways that you can sort of go at harm reduction. One of the ways that we've been doing it down in Iowa City at the Abbe Center, and we're doing it at the other Abbe Center locations too. We have a naloxone box, a free naloxone box, and so anybody can walk up to it completely anonymous and open up the box and take some Narcan with them. And so carrying naloxone is harm reduction, right? Having that near you if you're using an opioid is harm reduction.
Um, yeah, I have an analogy in my internal medicine life that, my first goal I set with a patient that is being seen for obesity is, okay, let's have our goal to not gain more weight. So I say, okay, all right, first step, let's not gain more weight. Okay,
Yeah.
let's have a goal of not gaining weight. Don't worry about losing it. Let's just get things under control. So similar, not exactly, but okay, the critics of that, and I'm sure you're prepared for this answer, is they're going to, well, we're enabling people to be abuse substances. How do you respond to that observation?
I think it depends on the audience. The data does not support that. The data does not support that we're enabling. It shows that people are more likely to come get care. This is a group of people that I think, and psychiatry does this too, which is really hard, but they don't get treated very well by the medical community.
No.
People who use substances do not get treated well. Some of them are not on insurance, right? And so, like, I think if you can show some humanity and some compassion, you're going to increase their chances of getting help for other things too, right? Like they might never go to the doctor. And you have one person that doesn't make them feel bad because they use coke or they use heroin. They might tell you some stuff. They might come back. They might come to their appointments, and overall, that's going to help with their health, right? I like the obesity analogy actually because I think sometimes it's not these big in quotes, big changes.
Right.
One of my one of the things I talk to people a lot about who have an alcohol use disorder for harm reduction is, all right, let's say you drink a 12 pack a night. What would happen if instead you only bought a 6 pack? Right? I'm not asking you to stop drinking, but what would happen if you only drank a 6 pack instead? Or if it's, a tall boy can, what if you drank just the regular size can instead? Can you just cut back to that? And any change is okay. Any change is good. And that's kind of a mantra in harm reduction, right? Any positive change. That's what we're going for.
I brag. I mean, that I've never discharged a patient from the hospital against medical advice. Right? I've never said, haven't signed the AMA. I've always went and seen them and said, okay, what's going on here? This isn't a prison. You want to leave. Okay, let's come up with a plan for you as a human being.
Yeah.
I'm not just going to abandon you because you want to leave. I'm going to formulate a plan that works for where you're at. Is it the optimal plan? No. But that's better than just abandoning a patient and saying, okay, well, yeah, just sign this form and go wander the streets with your medical condition. So I
Yeah.
like the concept of treating someone like a human being and finding a compromise to improve their situation. I like that, Chantal. I mean, I think
Yeah.
that's important. Um, what's it? I mean, to me, and you're absolutely right. I have to tell myself sometimes, even after 27 years and knowing this well, I have to tell myself nobody went to their guidance counselor in middle school and said, I want to be a drug addict.
No.
I hope I get hooked on Oxy and I just travel from ER to ER the rest of my
Yeah.
life looking for Oxy. That's what I want to do. No, that didn't happen. So whether it's heroin, at some point they were affected by the system and got trapped in it. Really.
Yeah. Yeah. Whether that's, like lack of ability to reach out for help, right? Like I think opiates are an easy example to talk about, right? Related to like the epidemic with prescribing. I also think though that it really like highlights a situation that of physical dependence, right? So like if you're somebody who maybe you use heroin or you pop a pill, right? And you're doing it to have a good time, that opioids will cause euphoria. We know that. They also
Right.
get rid of pain. There are different things that happen from it. Um, if you keep going back to that for whatever reason, you're trying to, get higher or have more euphoria. Maybe you like how you feel because it numbs you out. Maybe it helps you escape from a really terrible life situation. Maybe it helps you be more social, right? Whatever it is, you go back and you use, and eventually you develop a tolerance. And when that tolerance gets developed, you're going to need more. And that's where things kind of get messy, right? Because needing more, like that's where we see overdoses, but that's where we see withdrawal. And if you've ever seen someone in opiate withdrawal, it's man, it looks terrible. It looks like they feel awful. And knowing that, and they're just in diffuse pain, diarrhea, sweating, just like really uncomfortable, and they know exactly what will fix it.
Right.
I know exactly what I can do to make all of these symptoms go away, right? Um, that's hard. And it doesn't last like a couple hours. It lasts for days.
Yeah. Yeah.
And so I think remembering that, kind of like you said, like someone's goal wasn't to become dependent on a substance.
Ye-
Um,
Yeah. There's um, I can't remember which story it's from, but there's a Sherlock Holmes uh, story. I think it's the Adventure of Sherlock Holmes, but they talk about opium and how this one aristocrat's addicted to it, and he's reached the point where taking it, all it does is prevent withdrawal. He
yep,
doesn't even get a high from it. It's just
right.
constantly trying to prevent that withdrawal.
Yep,
Um, and that's yeah, it is. It is not pretty. Someone that's abstaining
yeah,
syndrome or withdrawing from that. There was
yeah,
an after school special, I think it was, with Robbie Benson, and he withdraws from heroin. And I probably saw it like when I was in the early 1970s, when I was like 6 or so, and it still scarred me my
yeah,
entire life. And maybe some way it influenced me not to do heroin. I don't know, but
yeah,
it was bad,
yeah,
and scary. And you're right. And all it takes is, because not to get in the weeds here, but people that were drawing from alcohol, they're kind of oblivious to what's going on because they get in the whole hallucinatory, they're dissociated from what's happening to them. They're
sure.
confused. But yeah, your people that are withdrawing from opioids, they know exactly what's going on and they know exactly what will fix it. Um,
And that's
and
really, yeah,
it's
that's tough.
yeah,
Cause like,
I always try to give them symptom relief as much as I can when I'm
oh
treating these
yeah,
patients.
yeah. And I talk about like, as I have my coffee sitting in front of me, like I've got a caffeine dependence. If I don't drink my coffee in the morning, I'll hit noon and I have a headache, a very specific type of headache too, where I know it's because I didn't have enough caffeine. I get sweaty and like I feel nauseous. And I know that I just have to go drink some coffee and it's going to go away. Like, and that is uncomfortable, and it is not the level of withdrawal that people withdrawing from opioids go through. Like,
Right. Absolutely.
it's so much milder and it's so uncomfortable already. Um,
What, not that I'm looking for a percentage, but just maybe a general trend in your experience, getting establishing that doctor-patient relationship in the setting of harm reduction. Does it progress people to making the goal of improving their life and maybe getting off substances?
yeah, I think I've seen that. I think it does. I think there's different levels too of harm reduction, and I kind of would consider myself as being like a little bit radical when it comes to that, right? And so I tell patients, I do not believe that drugs are inherently bad, and I do not believe that people who use drugs are bad. And I think some people would have a hard time with that, right? Like, and that's fair. That's fair. Admittedly, the drug I probably struggle with most, like personally, like when I hear people using it is alcohol, because I've had experience with people who have used alcohol in my family and it didn't go well. So in my head, that one's tough for me and it's hard to get around, but at the end of the day, they're still a person, right? It's just that the drug that they are using, their drug of choice, is legal after age 21. You can go to the gas station and get it. But alcohol is not inherently bad, right?
No.
It's the dependence, it's the relationship that you have with it. Um, and so sometimes people's goal is not to stop use. And that's a conversation that I have with people too, that like, look, I'm not asking you to be 100% sober, right? Like, that is not my goal. If that's not what you want, that's not what I want. And some people get to the point where they say, no, I think I have to stay away from everything. Um, and sometimes harm reduction too, right? Like if someone comes in, I'm smoking weed, I'm drinking, and sometimes I'm doing coke. What if we cut one of them out?
Yeah.
Like how big of an impact could that make if we cut one of them out? And yeah, so I think that like when you approach it that way, people are more likely to come back. They're more likely to be honest with you. And I think getting just being a person, talking to another person is what it comes down to. Because
Absolutely. It's that, you know, I say this in some other podcasts, and I say it in my medical practice. There's two types of patient relationships. There's paternal, where they really want to just be told what to do,
yeah,
right? It's the farmer that says, whatever, just tell me what meds
yeah,
and tell my wife because she's going to ask me what you said. So just call her. I don't want to.
yeah,
And then there's fraternal, where they really want to make the decision with you. And I think to be a good physician, you have to be able to have both those relationships on the same afternoon with different patients.
totally.
And I think this harm reduction really is in under that realm of fraternal, based on what you're telling me.
Yeah, autonomy, patient's autonomy is number one, for me, and that's always gonna be there, you know. If someone comes into my office and has anxiety, and I say, "Hey, I think that an SSRI will help." And they say, "Well, Chantal, I don't wanna take an SSRI." I say, "Okay. I think it would help. I think you could feel better.
Right.
I'm not gonna make you, and I'm not gonna make you feel bad because you didn't do it, right? Like, if in a couple of months you change your mind, let me know. I'll be here. I'm not gonna hold a grudge." Um, and I think that's important.
Absolutely. So if someone's struggling with substance abuse, how do they get help?
Sure. There's a lot of different ways. One service that we provide at the Abbe Center is MAT, or medication assisted treatment. So I would say most people people are most familiar with methadone. Like going to a methadone clinic every day, getting their methadone, and to stay off of heroin, for example, or a different opioid. Um, we use buprenorphine for opioid use disorder. And so it's prescribing an opioid, right? That acts on the same receptors, but not to the point that you're not getting high, right? But we're preventing that withdrawal from setting in. Um, and so that's a way that you can do that. We also use, naltrexone for alcohol use disorder. Same concept. Um, People can drink while they're on naltrexone, and so maybe it gives that person the ability to cut back on their own while also taking a medicine that helps decrease that drive to drink more. You could call and schedule with, not all of the offices have providers that offer MAT. And off the top of my head, couldn't tell you which offices, like satellite ones, do. Cedar Rapids and Iowa City do.
Okay.
And we're in the process of like making sure we have slots specific for that. So if someone were to call and say, "Hey, I specifically want to be seen for a substance use disorder, I'm looking for MAT," they can say that and hopefully get in maybe a little bit sooner because we've got some protection with those slots. We're really
Okay.
trying to get people in and help them and help with those problems. They just have to ask, I want treatment for MAT. I think it's important to say that specifically. And then we'll walk you through the process of what comes next.
Awesome.
Yeah. Therapy is an option. There's support groups, 12-step programs, right? People are familiar with AA. Um, but yeah, there's different levels of care depending on what you need. And so I think we're expanding with the CCBHC status of the Abbe Center, that we will be providing all of those levels of care, right? Residential, intensive outpatient, detox, outpatient. And those, you can kind of step down through those in a way too.
Well, Dr. Rozmus, thank you for joining me. I want to have you back. I think we ought to do one on alcohol and just the hypocrisy as society has with alcohol and other drugs.
Oh man. I'd love to talk about it. There's a lot of interesting history within this country when it comes to substance use, and like
Yeah.
what
Yeah.
is a quote unquote good drug and what is
Right.
not a quote unquote good drug.
Well, if you say, "Oh, I no, I sorry, I don't drink," people look at you kind of weird. But if you said, "Oh no, I don't use mayonnaise," I mean, they wouldn't like go, oh, what, you don't use mayonnaise? What happened? I mean,
Yeah.
it's just such a hypocrisy sometimes.
It's really, yeah,
And
it's really interesting. It's like this, it's a culturally more accepted substance, and like, right, you're weird if you don't use it.
right.
People don't say
Yeah.
that about other substances. They really don't. Yeah, that's an interesting, especially like you talk about binge drinking and college age kids, right?
Right.
Do they have a substance use disorder? I have a hard time with that because maybe they don't. They're drinking way too much. They're binge drinking. Do I think it's a disorder though? They're still going to school. If they're still going to school, they're still holding down a job, right? It's not a disorder.
I will say this, and we will that guys that were shy and became animated with alcohol in college have had trouble with alcohol later in life.
Yeah.
Others, including myself, that we partied and whatnot, just quit doing it once we grew up, right?
Yeah.
And I have friends that have had problems with alcohol, and I can reflect back and say, oh, so and so was just that quiet kid, and his personality came out when he would
Yeah.
party, right?
Yeah.
And so I do give that advice to young people to say screen for that. If you're someone that alcohol makes you animated and your personality comes out, you know, be wary.
Yeah.
So
Just,
we're going to
have a
have you
check.
back because I want to talk
Yeah.
about that.
Cool. Love it.
Once again, that's Dr. Rozmus, Chantal Rozmus. Thank you for joining me and informing our listeners about harm reduction and how it's used in the treatment of substance abuse disorders. If you or someone needs support, visit unitypoint.org to learn more about mental health services available at AbbeHealth. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.